who's Associate Professor of Medicine at Harvard Medical School and a member of the Division of Cardiovascular Medicine at Brigham and Women's Hospital, focused on prevention. And Dr. Mora will lead the lecture series with a topic on core concepts in cardiovascular prevention. So I think I can hand over the podium at this point to Dr. Mora.
Good morning, everyone. It's my pleasure to talk to you today about cardiovascular prevention. These are my disclosures. So today's objectives will be first to review current challenges for cardiovascular prevention, to review evidence and updated guidelines on lifestyle, cardiovascular risk assessment, cholesterol management, blood pressure management, and aspirin. So these are the leading causes of death. On the left here is in 2007, you can see cardiovascular disease was #1 cause of death in the US. Unfortunately, in 2017, we still have cardiovascular disease as the #1 cause of death. And that hasn't changed much, even though the age-adjusted declines have been gradually flattening off. Now, this is the same worldwide. Globally, cardiovascular disease is also the #1 cause of death worldwide in developing countries and in OECD countries. If you look at the bottom of this slide, these are the risk factors. So these are risk factors for all deaths. And you can see in 2007, the top 3 were dietary risks, tobacco, and high blood pressure. In 2017, there's still dietary risks, and high blood pressure is #2, and tobacco is now #3. I'll also point out to you that the other causes of risk factors of death in 2017 involve cardiovascular risk factors such as high blood sugar, high BMI, high cholesterol, impaired kidney function, air pollution, and low physical activity. So keep that in mind, that these are causes for all-cause death. So the take-home messages from the lifestyle section of this course is that lifestyle interventions should begin early and underlie all preventive efforts. Risk stratification is the key to prevention, in particular for targeting drug therapies, and the intensity of preventive interventions should match the level of cardiovascular risk. Now, prevention can be categorized into primordial, primary, and secondary prevention. This is a schematic of how we can think about it. Primordial, which is the base of the pyramid, is basically the social determinants of health. We've heard a lot about that recently with COVID, but these are things in particular, including socioeconomic status, poverty, literacy, urbanization, pollution, etc. Primary prevention is when we're trying to prevent the first occurrence of clinical cardiovascular disease, so first MI, first stroke. And you can have risk factors such as smoking, hypertension, dyslipidemia, but we're trying to prevent the onset of clinical cardiovascular disease. Secondary prevention at the top of the pyramid is really we're trying to prevent secondary events, recurrent events, or mortality. Now, the 2019 ACC, American Heart Association guidelines were updated for prevention. This talk will summarize the main take-home messages. They do have now specific recommendations for patient-centered approaches to prevention. They highlight a team-based care approach. This is in particular important for prevention, not just for heart failure and other systemic illnesses, but also for prevention, because it's really hard to do it just on your own. Shared decision-making between the patient and the healthcare provider should inform discussions, in particular for drug therapies. And they also, for the first time, emphasize social determinants of health. They underlie that these should really be part of prevention. So what are social determinants of health? Well, the WHO has classified them for us here as shown on the schematic. They can be thought of in 2 parts as structural determinants. And these are the environmental factors, the things that an individual cannot really easily change. These are things like what's their socioeconomic position or social class, gender, ethnicity. Now, these underlie the intermediary determinants. So intermediary determinants of social determinants of health include things like behaviors, psychosocial factors, specific living conditions. And these all impact our health and well-being. And in fact, the 2030 AHA goals that were just recently released, they actually make health equity the fundamental goal, to increase health equity, in particular for extending living lifespan free of illness. So health equity, remember, is very important, in particular for socioeconomic status. Equity in wealth equals equity in health. Keep that in mind. Now, part of the psychosocial factors is stress. So I figured I'll highlight this slide because we've all been under a lot of stress recently with COVID and other stressors. I think as healthcare providers, we're very aware of job strain, of long working hours, of perceived stress, etc. But keep in mind that even things like watching a World Cup soccer game can be thought of as stress. In general, people talk about stress, they're talking about toxic stress, the stress that really causes harm long term. What's interesting is in this summary meta-analysis that was conducted, while stress increases risk of cardiovascular events in everyone, you can see here in the general population, these are people without, not at high risk for cardiovascular disease, that the relative risk for cardiovascular events was about 20 to 30%. That's actually similar to about the magnitude of effect of a standard deviation increment in LDL cholesterol. Now, in higher risk populations shown at the bottom, these are patients with risk factors for cardiovascular disease or already with cardiovascular disease. Stress actually it plays a much bigger role. Here, the relative risk is like in the order of 2 to 4. So these are important factors. And in fact, people who already have cardiovascular disease, it's been known that stress will potentially promote an acute coronary syndrome, but also increase their risk long term. There are other sources of psychosocial factors I didn't go into, such as depression and other factors. So we'll talk about some of the other lifestyle factors that we can counter cardiovascular disease. We'll start with a case, so please be prepared to vote. This is a 57-year-old woman who is her BMI is 32, waist circumference is increased at 36. Her blood pressure and cholesterol are shown below. So in order to decrease her cardiovascular risk, what lifestyle advice would you not recommend? So you would recommend all of the following except for A, Mediterranean dietary pattern, B, replace the saturated fat with polyunsaturated fat, C, advise weight loss and increased activity, D, reduce the sodium to less than 2,400 milligrams a day, or E, reduce total dietary fat. Remember, please vote on the one that you think you would be least likely to recommend to her. Okay, that seems like we have a good distribution there. So most of you thought you would be least likely to recommend to her to, there's like sort of a breakdown between 3 things. I guess most of you said you would not necessarily recommend reducing total dietary fat or sodium. Some of you thought maybe you wouldn't recommend replacing saturated fat with unsaturated fat. Okay, well, we'll talk about these more in the next few slides, but basically, the correct answer is E, which is the one you're least likely to recommend to her right now is reducing total dietary fat. That's because the guidelines have changed in the past and recently from that now we no longer have to restrict total dietary fat, but we do recommend now replacing saturated fat with polyunsaturated fats. And we'll go over some of that data. In fact, replacing saturated fat with carbs has not been shown to be beneficial. That's been studied with the Women's Health Initiative randomized trial. Mediterranean dietary pattern is associated with about 20 to 30% or more reduction in cardiovascular events. Weight loss and increased activity, who would not benefit from that? And reducing sodium is also, in general, for general populations, a good thing, especially if you're hypertensive. Okay, so AHA Life Simple 7 is one way to think about these important lifestyle and cardiovascular health metrics. So AHA in 2010 decided these simple 7 parameters summarize the main take-home message for cardiovascular health. Get active, eat better, lose weight, stop smoking, control your cholesterol, manage blood pressure, and reduce sugar. And the specific details are shown on the right. But the important thing to keep in mind is that we can all do better in these 7 metrics. And these 7 metrics were recommended in 2010 with the goal to improve Americans' health. And we have gotten better, in particular for smoking cessation and for controlling cholesterol, but we have not gotten better on diet or weight loss. And in children, physical activity has actually not gotten better either. So the AHA Life Simple 7, as shown here, relate to cardiovascular events, to lifetime risk of cardiovascular events, but also to mortality, including non-cardiovascular mortality. So what's shown here on the slide is that if you had a good score, meaning you met most of these 7 criteria in terms of the ideal health, you were in green. And it's shown here for men on the left and women on the right, and for whites on the top and Black individuals on the bottom. You can see that the more you had of these risk health metrics that were good, that you basically did not get cardiovascular disease. So remember, these are people who were age 40 to 59 at entry into the study, and they were followed for an additional 40 years. So basically, if you're a Black man who has really good cardiovascular health metrics, you're going to not have cardiovascular disease really during your lifetime. On the other hand, if you do have many abnormalities in these risk factors, then you're going to have a really high lifetime risk, which is about 40%. As shown here. It turns out white women have the best profile for these cardiovascular health metrics, and Black men are the worst in general in terms of these profiles. So there's a lot of health inequities in these cardiovascular health metrics. Now, in terms of diet, that's actually the worst, the one that Americans always score worst on. In fact, only about 5 up to 10% of the US population, depending on how you assess diet, are really following guidelines. So in 2015, the US Dietary Guideline Committee gave recommendations, and they recommended 3 beneficial dietary patterns. Notice here the emphasis is on dietary pattern. So it's the pattern emphasis, not so much the individual components. And they basically recommended a healthy Mediterranean style diet. Now, what's interesting is in 2020, they also updated their guidelines. They're still in draft form, but you can see them on their website if you go to the website. And they're very similar, again, emphasizing the dietary patterns with the Mediterranean style pattern. Now, what's the data? So the PREDIMED study was conducted in primary prevention. It was about 7,500 individuals. These were all in Spain. But they had risk factors. They were high risk for CVD, and many of them were on statins and treated well for their blood pressure. And they were randomized to 3 arms, as shown here. A control arm that was told basically avoid low fat, because at that time, that was the AHA recommendation. And they were also given just general advice. Now, in the other 2 groups, they were randomized to a dietary intervention where they were actually had to change their diet, increase their intake of vegetables and fish, etc. But also they were randomized. Half of them got also EVO, extra virgin olive oil, and they were supposed to take more than 3.5 tablespoons a day, so about 4 tablespoons a day. And that's a day, not a week. And then nuts, and here they were taking 30 grams of nuts. Now, what you can see here is that there was about a 30% reduction in cardiovascular events. There was also improvement, actually, in other endpoints, such as it prevented diabetes, new onset diabetes, and those who are not diabetic. It also helped to decline cognitive decline over time, helped to improve that. And then in women, also, the olive oil arm reduced breast cancer risk. Now, that is the basis for some of the recommendations. But there's a lot of other data. This is just an umbrella meta-analysis of over 12 million individuals. And this meta-analysis summarizes for us the data from both randomized trials and observational studies. on the Mediterranean dietary pattern. And they're looking here at adherence to the Mediterranean dietary pattern. And those individuals who had greater adherence had greater reductions in not just heart attack and stroke, but also in new onset diabetes and in cardiovascular death, as shown here. The relative risk reductions range from 30 to 40% across the studies. And that's regardless of whether you're on statin or not. In fact, in Predimed, many of the patients were on statins, and there was this added benefit. And so keep that in mind. And also, when I'm talking to the patients, it's not an all or none phenomena for diet or for cardiovascular risk factors. It's really, we're aiming to improve them. So better adherence would be about a 2-point improvement in the Mediterranean diet scale on a scale of 0 to 15. So in that case, you're basically just trying to nudge them to be a bit better and to do it more consistently. And that's where the benefit is. Of course, there's greater benefit if you do more of the time. So remember the 90-10 rule or 80-20 rule. Okay, omega-3 supplements, we get a lot of questions about that. So a lot of data has come out recently, and in the past year, there have been a few meta-analyses looking at omega-3 supplements, in particular after the publication of the Reduce It trial. I will not go too much in detail on Reduce It because that was really for secondary prevention. It did include about 30% patients with diabetes and increased risk for cardiovascular disease based on their risk factor profile. Reduce It results are shown here. So for myocardial infarction, you can see that omega-3 in these about 13 randomized trials involving over 120,000 participants, there was about a 10% reduction in the risk for myocardial infarction. Depends if you include Reduce It, the effect is a bit more because Reduce It had about a 30% relative risk reduction. So if you include Reduce It, you get about a 12% relative risk reduction in MI. And for CHD death, you get about the same thing, about like a 10% relative risk reduction. Now, interestingly, for stroke, omega-3 supplements have not been shown to reduce risk of stroke. Only Reduce It trial was the only trial that showed benefit for stroke, but none of the other trials really shows the benefit for stroke. So you're really using it for more coronary prevention. So these are the recommendations from the guidelines. They emphasize taking, Mediterranean type diet with increased vegetables, fruits, legumes, nuts, whole grains, and fish. And if you're wondering more about that, I did include a few slides at the end for your review and the additional slide section summarizing the Mediterranean diet and also what was the intervention in Predimed. They also now, this is new, they recommend replacing saturated fat with dietary, either mono or polyunsaturated fat. So monounsaturated fats would be something like olive oil or canola oil. Canola has both, but it's predominantly mono. Now, polyunsaturated fats, if you're wondering which ones these are mostly safflower or soybean oil. And I did include also a slide that details the percentage of polyunsaturated fats in various oils that are commonly used. That's also in your additional slides. The data for that is shown here on the right. These are 4 randomized clinical trials. They're small. These are the number of cases you can see in the 100 range. So not the type of cardiovascular, large clinical trials that we're used to. And this data is back from the 1960s and 70s. But you do see that in those trials where they did replace saturated with polyunsaturated fat, not with carbs, but with polyunsaturated fats, that there was a significant reduction in this meta-analysis of about 30%. It's again, not the best level evidence, but they are randomized trials that were conducted. They were done before statins and other commonly used preventive therapies. And then also in general, the diet should contain reduced amounts of cholesterol and sodium can be beneficial. Okay, now smoking. Well, smoking remains the leading cause, one of the top leading causes of death. It's number 3 currently in the US. Globally, it has a big impact. And while in the US, recently we've made progress, the rates have continued to come down over time. However, if you look here, e-cigarette use shown here in this bar graph here over time has increased. Between 2011 and 2018, there's been a great increase in e-cigarette use. Now, of note, the long-term consequences of greater e-cigarette use is not really known. Obviously, there are acute lung toxicities from it, EVALI, that has been categorized, and that's why it's being recommended not to use them at all, especially in the youth. Remember to ask about the 5 A's, ask about smoking, advise to quit, ask willingness to make an attempt, assist if ready, and arrange follow-up. These are actually very good for all behavioral interventions. Obesity, this is a huge risk factor, not just for cardiovascular disease, but in particular for premature deaths. So unfortunately, we have done a really poor job in controlling obesity over time. It's shown here, this is a map of the US for BMI over 30 from 1990 to 2030. It's expected by 2030, 1 of every 2 US adults will be obese. Just think about that. And some states, as shown here in the extreme colors, especially in the southeast of the US, the stroke belt, that will be even more than 1.5. So it's really a scary concept. And BMI more than 35, this is severe obesity. We weren't even tracking this before. Look at the US in 1990 or even in 2000. So unfortunately, this is really also increasing and as well. Now, what are the health consequences of obesity? Well, we do know that not just for COVID, obviously obesity has been highlighted a lot recently because of the COVID risk, but also for diabetes, huge risk. These are data from the Nurses' Health Study, multiple publications, but also have been shown in many other studies, increases risk of diabetes like manyfold. But also hypertension, CHD, obesity-related cancers, endometrial and breast for women, total mortality and stroke risk. So this is really something to underscore. How can we control obesity? Well, one of the ways is through leisure time physical activity. What we do know about physical activity is that the biggest bang for the buck is going from couch potato to somewhat active, as shown here. Now on the slide, I show here in the bar, the vertical bar is the currently recommended minimal activity. So in 2018, those guidelines were updated for Americans, and they now suggest more than 150 minutes per week. So they actually recommend somewhere between 150 and 300 at least. So that's about 2.5 hours to 5 hours a week. And that is really, as shown here, that's been associated in this meta-analysis with about 30% relative risk reduction in events, in mortality risk shown here, but also in non-fatal events. However, for people who cannot meet that level, you can see here, even people who did some amount of physical activity, even if they did not meet the current guideline recommendations, had a 20% reduction in events, in mortality even. So now, of course, if you did more, you had greater benefit, up to like at least about like 5 to 10 times the recommended activity level. Once you get to really extremely high levels, there could be potential, slight increase. So it's a curvilinear relationship. But keep in mind, the biggest bang for the buck is getting the couch potato to move somewhat. But if you are already on moving, then move more. And that's really the recommendation. How about sedentary behavior? Well, a lot of us are worried about that, especially if we're sitting a lot. Even though we're trying to be physically active, say in the evening or on the weekend. So what's the detrimental effect? As shown in this graph on the right, sedentary behavior has many detrimental effects on the vasculature, on obesity, on many inflammatory and cardiac biomarkers, as well as on insulin sensitivity and atherosclerosis. Now, what's shown on this meta-analysis of over 850,000 individuals, this meta-analysis was just published last year. What you can see here is that there's increased risk for cardiovascular mortality for people who are sedentary, but that's in particular for those who have lesser amounts of physical activity. So this analysis stratified by levels of physical activity, going from if you did 5 minutes a day of physical activity, all the way up to more than an hour a day of physical activity. So people who did more than an hour a day of physical activity, there really was not much increased risk in terms of sedentary behavior. However, for people who did less than an hour a day, there you can see here that there was increased risk for sedentary behavior, especially if you sat more than 6 to 8 hours. And those who are really doing no physical activity, you really want to limit their sedentary behavior, because even 4 hours a day was associated with increased risk. So keep that in mind as you recommend things to the patient. Now, in 2018, as I mentioned, the physical activity guidelines were updated. So this is their summary recommendation. They recommend 2.5 to 5 hours per week of moderate intensity, or half that amount if you're doing vigorous intensity activity, or you could do a combination. What's different from before is they no longer recommend that it has to be in 10-minute chunks. So now you can spread that out. You can do 5 minutes, a few minutes here and there. It doesn't have to be 10-minute blocks like they used to recommend. They also recommend muscle strengthening activities, as these have been shown to have added benefit, and they recommend at least twice a week. They also recommend to sit less, but notably the sedentary behavior literature has not really quantified so much the parameters. So the guidelines could not agree on any specific parameters, but keep in mind the recent study I just showed you, 2019, that came out after the guidelines. And then they also, of course, in very high risk patients, such as ACS or heart failure, they recommend medical supervision programs. So bottom line for lifestyle is it should begin early, underlie all our preventive effort, and keep in mind most cardiovascular events and diabetes are actually preventable with better lifestyle. Some is better than none for lifestyle, and more is even better. So now we'll talk about risk assessment and cholesterol. Okay, so we'll start with this case. This is a 37-year-old African-American woman, comes in for a pap smear. She doesn't really use any drugs or tobacco or alcohol. Her father had an MI at age 49, so that's premature. For a man, it should be less than 55. He was a heavy smoker. Her mother is still alive, 61, has diabetes and hypertension. She has severe obesity. Her BMI is 45. And this is her blood pressure and her rate. What's the most appropriate next step in the evaluation of this patient? So would you measure high sensitivity C-reactive protein? Would you measure coronary artery calcium? Would you measure serum homocysteine? Would you do an exercise EKG stress test? Or would you measure a lipid panel? Please vote. All right, so this one seems to have been an easy slide. So yes, you are right. The next best step is to measure a lipid panel. Now, measurement of high sensitivity C-reactive protein and coronary artery calcium can be used if you're determining, if you need help deciding should she go on a statin or not. Serum homocysteine has really gone out of favor. And exercise EKG, well, most of the time you don't need that, while physical activity levels and physical fitness levels based on a stress test are really strong predictors of mortality. However, you don't really usually need an exercise test to do that. You can usually ask the patient. Measurement of a lipid panel is what's the next best step in this evaluation. So what's new? Well, what's new is that the guidelines no longer recommend fasting. They say you can have fasting or non-fasting lipid profiles. And that's starting around age 20. However, actually, we should really be screening children when they're around age 10. But if they have family or history of premature disease, they should even be screened earlier, even around age 2, in order to evaluate for familial hypercholesterolemia or inherited genetic abnormalities. And they do also say that if you really wanted, and if you did it non-fasting and their triglycerides were more than 400, you could repeat a lipid profile fasting if you wanted to document fasting triglyceride level, although that's really not necessary most of the time. What's considered high for non-fasting triglyceride is a level more than 175 milligrams per deciliter. Okay, so estimating risk. We have a lot of tools that we can use. We have the ASCVD risk estimator. This is an equation, an online tool that you can, or an app that you can go to with the pooled cohort equation, PCE. You can also estimate lifetime or longer term risk. That's actually really important for younger individuals who in the short term have lower risk, but they have long increased risk over time. If you're in doubt, you can also check risk enhancing factors. So these are new based on the guidelines from 2018, 2019. We'll talk about them. And also you can check a coronary artery calcium level. So who should be considered for statin? I here recommend Dr. Jorge Plutsky's talk that you can listen to, but I will be just highlighting the main take home points. So the people who should get statins for prevention are very high risk. So if you have already clinical cardiovascular disease, if you have a very high LDL cholesterol, more than 190, or if you're in primary prevention and you don't have already cardiovascular disease, but if you have diabetes, you should get it pretty much. And then if you're primary prevention without diabetes, you calculate the PCE risk. And if that's more than 20%, then they should get it. If it's between 7.5 and 20%, then you look at the risk enhancers, and the coronary artery calcium could help you decide. Notice in the prior guidelines from 2014, this threshold here was 7.5%, but they increased it to 20% because there was a lot of studies suggesting that maybe you were overpredicting risk in people, especially if they're healthier. So now they say if it's 20%, you go on a statin. At least you have a discussion with the patient actually about going on a statin. And then if it's between 7.5 and 20%, you discuss that again and look at their risk enhancing factors. I summarized for you the guidelines in this slide. Again, if you have clinical CVD, very high LDL or diabetes, you basically go on a statin. Everybody gets lifestyle. As shown here, lifestyle for everyone. And statin, I put it in a graded shadow depending on your risk. So if you're really low risk, less than 5%, then you don't really need a statin for most people. If you're intermediate risk or borderline risk between 5 and 7.5 or 7.5 and 20, then you look at these risk enhancing factors, and you can also look at coronary artery calcium. And if you're 20% or higher, that's considered high risk, and you can discuss with the patient going on a statin. So what are the risk enhancing factors? These are new since the 2018-2019 guidelines. So what they are is various things. You can look at chronic kidney disease, their GFR between 15 and 59. There are some high-risk ethnicities, for example, East Asians, but also African Americans and Native Americans have high risk. Family history, and here we're looking for premature events in particular, and the younger the age of the family member having an event, the more the risk. Pregnancy and menopause. Now the guidelines include 2 factors for women, but there are many other factors related to pregnancy that we can look at. But in particular, they highlight preeclampsia and premature menopause. Metabolic syndrome is a risk enhancing factor, and chronic inflammation, as well as biomarkers. The biomarkers could be inflammation like CRP that Paul Ritker has a talk on recorded, or lipids, including here ApoB more than 130 or triglycerides more than 175, high lipoprotein little a, and ABI that's low. Now, coronary artery calcium does help for risk stratification. I just show here one study that shows even if you don't have a current statin indication, but you have a high CAC score more than 100, these people are at increased risk, and it helps to risk stratify. So if you're in doubt, you can always consider getting a coronary artery calcium scan. How about adding a non-statin? Well, those really are reserved for the very high risk cardiovascular disease. And in those people, multiple events or very high levels of risk factors or multiple risk factors, then you consider adding ezetimibe to get their LDL cholesterol less than 70. And if it's still high, then you also consider PCSK9 inhibitors for further treatment. Here is just a summary slide for the European guidelines. They're similar to the US guidelines, but they do highlight using non-HDL cholesterol and ApoB, in particular for people with high triglycerides, diabetes, insulin resistance states, metabolic syndrome, or very low LDL cholesterol. Now, this is another case, 26-year-old Hispanic male, so a young guy, smoker. He has multiple borderline risk factors. BMI is 33, LPA is 70. Using this assay, the upper limit of normal was 30 milligram per deciliter. So he unfortunately did have an MI. And one day prior to his MI, he saw you in clinic. So does he have any of the risk enhancing factors? Again, focus here on the risk enhancing factors that the 2018-2019 guidelines recommend can be considered if a risk decision is not certain. Please vote. You can actually vote for more than one. So people are voting still. So people voted for high LPA, high lifetime risk. Smoking. Obesity. So yeah, there's a distribution of answers. I mean, most of you said high LPA, but there's a range. And again, you can answer more than one. So I checked here 2 that I think are most appropriate, which is he has a high lifetime risk. Even though he's young, he has a high lifetime risk. He also has a high LPA. Again, the guidelines now recommend more than 50 milligram per deciliter, or if using the nanomole per liter, it's 125. Obesity is not considered technically a risk enhancing factor, although metabolic syndrome is based on the AHA guidelines. And smoking is actually a major risk factor. So it's not really risk. I mean, well, it's a major risk factor, not really a risk enhancing factor per se. Okay, so for cholesterol, first you assess risk. You use a number of tools, including risk enhancing factors, coronary artery calcium. Statins are added for the higher risk individuals, and PCSK9 inhibitors can be considered for those at very high risk, usually secondary prevention or familial hypercholesterolemia. And here, lower is better. Okay, blood pressure and aspirin. So blood pressure, again, I showed you the slide earlier. You can see here blood pressure was the number 2 risk factor responsible for all-cause death in the US. So let's talk about that briefly. So in 2017, the ACC/AHA guidelines now recommended that hypertension be defined, stage 1 hypertension, as blood pressure 130 to 139 over 80 to 89. That's different from prior guidelines where this was really considered pre-hypertension, and they consider now stage 2 being 140 or higher, or 90 or higher. And those guidelines also recommend assessing cardiovascular risk. So if your 10-year risk is low, less than 10%, that's again using the PCE equations, everybody gets heart healthy lifestyle that we talked about. I give you a slide with specific recommendations on that. But you can see here, everybody gets lifestyle, but you get drug therapy also for high blood pressure. If your 10-year risk is less than 10%, but your blood pressure is at the threshold of 140 over 90. If it's a threshold of 130 over 80, then even if your risk is high, more than 10%, or if you're diabetic or have chronic kidney disease, they recommend pharmacotherapy. Just to keep in mind, there's variation in interpretation of the data. So the 2020 ADA recommendation gives a threshold suggested of 15% as being high risk for diabetes, and the European guidelines actually did not change the definition of hypertension. They still consider high normal 130 to 139, and they only consider grade 1 hypertension 140. So there is variation in these guidelines, but the take-home message is, I think, very similar. And they all emphasize risk-based assessment, assessing cardiovascular risk. And for most patients, the goal is less than 130 over less than 80 if you can tolerate it safely without too many side effects. And note that really any of the antihypertensive drugs are helpful, and you can take into account other comorbidities in selecting them. Aspirin. Okay, so aspirin has been really controversial. It's gone sort of from swinging all the way from the positive end of the spectrum to the negative end of the spectrum. So where are we in 2019? So we have now updated data. There were several studies that were published recently. So in the updated meta-analysis for primary prevention, looking at low-dose aspirin. So here we're talking about, in the order of 80 to 100 milligram per day. There is a reduction in ischemic stroke of about 20%. There's also a reduction in MI of about 15%. This is greater in men, and ischemic stroke, greater reduction in women. There's not a significant reduction in mortality, but there is reduction overall in cardiovascular events. But this comes at the cost of bleeding. And we all know that aspirin can increase risk of bleeding. Major bleeding can be increased by about 50%, 40%. So we always have to weigh the risks and benefits of aspirin. And so the recent guidelines for ACC/AHA recommend that low-dose aspirin can be considered for individuals who are 40 to 70, but who are at higher risk, and they don't give a threshold. And they say they shouldn't be at increased bleeding risk. And they say to avoid it in routine everybody, or avoid also in people older than 70 or have bleeding risk factors. The European guidelines say forget about aspirin for primary prevention, and the USPSTF guidelines are being updated. The ADA guidelines are recommended here. They recommend low-dose aspirin for diabetic patients who are at increased risk of cardiovascular disease, about a 10-year risk more than 10%, and they have other risk factors. And they say to avoid it if you're low risk. So we have developed an aspirin guide app. This is free and available that help you determine the risk and for CVD and the risk for bleeding to help you assess risk benefit. So the take-home message is from today's talk is cardiovascular disease remains number one cause of death. We should always assess risk. And now we have new risk enhancing factors we can look at. Lifestyle, the Life Simple 7, and statins for the higher risk individuals. Blood pressure control for most people should be less than 130 over 80, and also includes risk assessment And aspirin low dose, again, also includes risk assessment and avoid in low risk individuals and the elderly. So I think that's it. Actually, I'm happy to take any questions.
Sonia, that was absolutely fantastic. And you've given us a couple of extra minutes during which I think we can take some high value questions. So let me pull those from the audience for you. One is really about, I'm going to do these rapid fire. So LDL, can it be too low? And particularly in patients who are elderly, does it affect very low LDL affect cognitive function?
Right. So we know from the many now randomized trials that you can get safely to as low as like 40 milligram per deciliter of LDL cholesterol, or even lower. Like in some of the PCSK9 inhibitors, it got to 20 milligram per deciliter, and there was no side effect, at least in over the trial duration of several years on cognitive function. Actually, part of the Ebbinghaus trial did look specifically at neurocognitive function, so we don't really worry about that.
Great. And dietary patterns to reduce cardiovascular risk. You mentioned the Mediterranean diet. Other patterns, vegan diet, Ornish-style diets.
Right. As long as it basically includes a lot of vegetables, legumes, nuts, seeds, herbs, fish, and avoiding red meat. In particular, the processed red meats are really harmful, and avoiding sugar-sweetened beverages or added sugar. So if you basically avoid processed foods and stick more to the lean, vegetables, legumes, and a little bit of meat is okay, as long as it's sort of very small quantities.
You mentioned use of non-fasting cholesterol. Doesn't that confuse the issue? Why have we shifted to that use?
It's actually much more practical, and actually it does not confuse the issue. In fact, actually, the LDL cholesterol doesn't really change with fasting or non-fasting, and neither does non-HDL cholesterol, nor does total cholesterol, nor does HDL cholesterol. So the only one that really can be variable is triglycerides. But now we don't really even target triglycerides. And so unless you're in a very specialized lipid clinics where you're really treating triglycerides per se, which again, like I said, it's not generally recommended to treat triglycerides. So unless you have a very specific indication, for most people, we don't even need to do that. So that's why the guidelines have focused in on non-fasting. In fact, it's been used now in Europe since like the past decade, and it's much better for patients, much better for the labs, much better for I think overall healthcare.
Last question, can you be too old? Is there a point at which preventative efforts become less relevant, an age beyond which we stop worrying?
Yeah, that's a good question. Right. So what happens is the traditional risk factors, their relative risk for cardiovascular events decreases as we age. So for example, if you're a young person with a high LDL cholesterol, that relative risk for cardiovascular disease is greater if you're young than if you're old. However, when we're old, our absolute risk increases. So when we're older, our absolute chance of getting a cardiovascular event is high. So even though the relative risk for each risk factor is diminished with older age, however, the absolute risk is high. So, it's a matter of weighing the absolute risk versus the relative risk. There is really no age at which it's too late to start or too early to start. And in fact, people who start off healthy and then end up having unhealthy lifestyle down the road do worse over time.
Thanks so much, Samia. I think we're out of time. So I want to thank you for your contribution, and we'll move on to the next portion of the program. Other questions we'll try to address over the course of time or get them to Dr. Mora for you.